Good afternoon, network, and thank you so much for joining in today. Today we have a very interesting session on HIV drug resistance. And today we have three different presenters We have Dr. Suilanti Sivile, who's our National HIV Technical Advisor. We have Ms. Judith Mziache and Mr. David Rutaguera, who will also be taking us through parts of the HIV drug-resistant cascade. So very exciting presentation ahead. Just a few house rules before we get started. So ensure your microphones are on mute. And if you've got any questions, kindly post them in the chat box or go to attend to them. So at this point of time, I'm going to invite our first
showing Sunday.
Okay.
Immediate.
Great. Right. Thank you so much. So just a few objectives that we need to take mind of until the end of the presentation is that we're going to discuss HIV drug-resistant testing service provision in view of the minimum package for sustainable HIV service delivery and the amended HIV drug resistance surveillance protocol. Our second objective will be to review provincial enhanced adherence counseling and HIV drug-resistant testing service provision. And lastly, would be to capacity build to manage patients with HIV drug resistance. So very, very exciting presentation ahead. So at this point of time, I'm going to call upon our National HIV Technical Advisor, Dr. Suilanti Sivile. Thank you so much for coming through today, and I hand over to you.
Thank you. That gentleman, you did the ball for over the weekend.
Thank you, Dr. Knight.
Yes.
And thank you, Network, for finding time to connect to this Monday's ECHO session. So all of us are aware of what's been going on with the changes in our funding landscape. Things are getting clearer, but as you know, because of that, we did prepare our minimum package of care. This as we look at our direction towards accountability. So change a few things. Next slide. And as introduced with the National HIV Program. So these are just learning objectives, I think already outlined by Dr. H. Next slide. So we'll start with 4 questions.
Great. So this brings us to our first poll question. And our first poll question reads, which of the following is true concerning HIV drug resistance in the Zambia minimum package for HIV service delivery? Option A, HIV drug resistance should never be done in Zambia because it's costly. Option B, HIV drug resistance should only be done after second-line treatment failure. Or option C, surveillance for HIV drug resistance after first-line failure, which is DTG surveillance, will be done in selected facilities, and HIV drug-resistant testing after second-line treatment failures will be done in all facilities. So which of the following is true concerning HIV drug resistance in the Zambia minimum package for HIV service delivery? So we got some good participation. Let's all ensure we participate. Your responses are anonymous. We're all here to learn, so please let's ensure we participate. Okay, I'm going to give it a few more seconds. All right, so I'm going to end the poll question now. Well done, network. And sharing with you results, Dr. Sivile, we've got 65% that have opted for option C, which is surveillance for HIV drug resistance after first-line failure will be done in selected facilities. And HIV drug resistant testing after second-line failure will be done in all the facilities, followed by 32% that are opted for B, which is HIV drug resistant should only be done after second-line treatment failure, and 3% chose HIV drug resistant should never be done because it's costly. And I'm sure we'll learn more during the presentation. Over to you.
You can have the second one.
It's interest.
So sorry about that small glitch. So we'll go to our next slide. And our next slide is our second poll question. And our second poll question reads, Suilanji Spiller, a non-alcohol misuser, is on TLD and has been on enhanced adherence counseling for 3 months. His repeat viral load is 500,000 copies per mil and is still non-adherent to ART. What is the correct next course of action? Option A will be to continue EAC and repeat viral load in 3 months. Option B, to do a genotype and continue his current ART. Option C, to genotype and switch to AZT3TC and darunavir-ritonavir. Or option D, refer him to psychiatric services but continue his current ART. Okay, so I'm going to repeat it again. Suilanji Sivile, a known alcohol misuser, is on TLD and has been on EAC for 3 months. His repeat VL is 500,000 copies per mil and is non-adherent to ART. What is the correct next course of action? A, continue EAC and repeat VL in 3 months. B, do a genotype and continue his current ART. C, do a genotype and switch to AZT3TC darunavir-ritonavir. Or D, refer him to psychiatric services but continue his current ART. So far, some great participation. Let's all ensure we participate. Okay, I'm gonna end the poll question soon. All right, so sharing with you results, Dr. Sivile, we've got majority, which is 43% that have opted for option D, which is refer to psychiatric services but continue current ART. Then 30% says continue EAC and repeat viral load in 3 months. 15% say do a genotype and switch to AZT3TC in darunavir-ritonavir, and 12% say do a genotype and continue his current ART. Interesting feedback, and I'm sure we'll learn more. Yeah. Okay, so okay. So over to you.
Yeah, so like I've said, we have a sustainability roadmap, and the vision is to have program, a response that we can own as a country, domestically, lead and resource as well, so that we can sustain the end of AIDS as a public health threat by 2030 and beyond. To do this, there is a need to reconfigure or change some of the ways we deliver our service so that they can be sustainable. And that's where the minimum package comes in. So this is a Zambia minimum package for sustainable HIV service delivery. We hope that it will harmonize some of the HIV services across the country and form a sustainable and cost-effective package that can be offered domestically, but also it should be used for quality assessment, and also to strengthen the governance of HIV services at subnational level. Next slide. So these are just some of the principles that were considered. You look at the epidemiology, how cost effective is that particular intervention? How feasible is it? What are the ethical issues around it? Acceptability and community engagement, and also social and economic impact of that particular engagement, intervention. So some of the revisions for the minimum package included those minimum services that have to do with HIV treatment and care services. So you can see that this is a three-tiered recommendations. We have those things in blue, in green, which are recommended, things that are in red, these are, or pink in here, which are not recommended. Then sometimes we do have things that are in between, which you can or cannot do. So really, if you look at things that are not recommended, is baseline viral load testing after first-line treatment, failure only, so this should not be done. Baseline viral load and HIV drug resistance after first-line treatment, these things should not be done. And of course, there are other interventions with regards to treatment. So this is a recommendation that we have right now, that if someone has failed first line, they should not undergo HIV treatment failure because of the cost. Yeah, next slide. And similarly, these are just some of the things that are required for labs. Even though that recommendation is done, we expect that labs should be able to do HIV drug resistance and other safety labs because they are required in certain scenarios. Next slide. So allow me to just talk about HIV treatment failure, because these are the individuals that need HIV drug resistant testing. Obviously, it's a persistent detectable viral load that is greater than 100 or than 1,000 copies. We still insist on this one. And we all know how we do the HIV drug, viral load monitoring. Next slide. Obviously, treatment failure can be clinical, immunological, and virological. Next slide. And these are the causes of treatment failure. Most of it has to do with, indeed, patient factors, which is poor adherence or drug intolerance and that sort of thing. Next slide. And how would you approach an individual who has is either they've fallen off or they're failing? The key is that enhanced adherence counseling, and obviously you screen for AHD. Then if the viral load is high, next slide, you take them into enhanced adherence counseling. We know that most of the individuals actually will resuppress, over 70% will resuppress because the causes are just that difficulty with adherence. So pretty much this is the protocol that we are all aware of, which you want to find the barriers or the reasons why this individual is failing so that you can help them. And they could be cognitive, socioeconomic, behavioral, and emotional. And these haven't really changed. Next slide. These are just how you do before the session. You prepare yourself. Next slide. But really, the session should start with the first session where you explain why you are doing it. Then you come up, you identify the barriers. After you explore and you know the barriers, you find strategies, then create a plan. Then in the next two sessions, you kind of review if the person has implemented whatever you've agreed, and you can go on and on. But after 3 months, if that person you feel they've been adherent or they've sorted out the challenges that they had, you are supposed to do a retest of the viral load. And if it's above 1,000, then the person has treatment failure, you have to switch regimen. If they are below 1,000 after that, then your EAC has actually worked. So I think that just the previous slide. So we do not recommend prolonging. You know, you saw that case of somebody who's an alcoholic. Yeah, you think you're having challenges, you do not prolong. You refer to the next care depending on what barriers you've identified. And in that case, better you seek psychiatric or professional intervention if somebody is an alcoholic. We know we do have this minimum, the basic package, primary healthcare package for psychiatric services. I think we do have clinical officer psychiatrists in the facility. So you refer the individual to such specialized care. Now, so this is just what you can do if an individual is non-adherent following that. Yeah, then there are other options that you can give, which we talk about. Yeah, but really, just to say that someone who has treatment failure does not mean they have indeed HIV HIV drug resistance. Now, our approach has changed. So you do have two sites. There are those sites where we are doing surveillance services for DTG surveillance, the so-called primary sites. So in these sites, once you repeat the viral load, and if on your right here, on our right here, and the retest is high, in this particular individual, you should draw a sample for genotype, then move them to the sequential second line, but have that genotype process, then you can change later on. So in the next presentation, we'll tell you where these sites are and so on, where these services could be done. For the rest of the facilities, in non-HIV drug resistance surveillance sites, you retest the viral load at 3 months after good adherence. Obviously, if someone is not adherent, there's no need to do that retest. Yeah, you're just wasting the sample. You know they're not taking the drugs. Yeah, so if it's above 1,000 copies, they have virological failure. On first line, you can switch them directly to a sequential second line, which I'm going to talk about what that is. And if they're on second line already, that's when you collect the genotype. Then you can have a consult to an advanced treatment center, because this is an individual who probably would need a third line care. So in those sites where you have primary sites, you only collect genotype from patients who have completed years, still have high viral load. So do not wait for genotype results before you switch to second line. They'll take long. And only central labs, unfortunately, we will not have genotype everywhere. So they're just Papa Belt, and here in Lusaka, it's ADH. And star genotype, you can optimize your second line. Yeah. And also we use these for the data for HIV drug resistance surveillance. Now, why we are doing HIV drug resistant testing? Remember, the key is surveillance, but we can also help us for selection of potent ARV lines, for especially those who are failing, we need second line therapy. Because we don't want unwanted or unwarranted or unnecessary switch to subsequent therapies. Yeah. So these are just guides from WHO to show that it's very important that we do this surveillance for HIV drug resistance, and sometimes we do surveys which when you find that there is too much resistance, over 10%, probably it shows you that there is something wrong, and you might need to move to other regimens. So for instance, if we start finding too much HIV, DTG resistance that we are depending on right now, we might need to maybe as a program look for other drugs. Yeah. So how we do this, obviously we do routine surveys, then there is this routine, we do surveys, periodic surveys, then you can do them also as routine surveillance using a cardless study. Now, this slide, I just wanted to add to show that individuals who are on second line are about 40,000, but we are not seeing this number really growing, especially when we ask facilities to follow the EAC cascade. You can see that of everyone that is unsuppressed, very few people have that first who complete the EAC. Out of that, again, very few. These are percentages of the previous, so they are not numbers. You can see that at the end, you have unsuppression rate is very, very low, but this is not being done. So we are losing patients through the cascade. And the core is, we think there are more patients, and there's a lot of resistance to DTG and also to other PIs, because even if this, just to show that even if DTG is a new drug, we've seen case reports, this is from here, of individuals, and these are just a few cases, but there are so many. So this resistance is there. We are not looking for it. We are not finishing our cascade, but a specific call for those individuals who are on third line or on second line, that when they fail, we need to do this genotype so that we put them on second. Yeah, so a caution of interpreting genotypes for those that will have results for those sites. Treatment is
okay,
don't just look at the results. There are other things. So that's why this should be done with expert opinions. Yeah. Sometimes the sample was bad. At the end, the interpretation should be done with an expert, and that drug history is really key. Now, I just wanted to show you that as you are moving to second line, we now have some guidance of WHO. This just shows how the regimens have changed over time. But WHO has released guidelines, and this is the new recommendations, and soon we will put them in the guidelines. In short, the new recommendation is that darunavir is a preferred PI for second line. You can have those alternatives. In our program, atazanavir, we've removed it, and we have a little bit of lopinavir. But most importantly, that for adult, adolescents, and children, TAF or TAFET is recommended. It's a preferred option in initial and subsequent regimen, even if that individual has had exposure to TDF or AZT. So what it means is all our patients should either be on TDF or TAF. It's an anchor. So you can recycle. Now we have the evidence that if somebody fails TLD, the second line should be TDF, 3TC, and darunavir. And we have long-acting injectables also being recommended. And where possible, we will see this in our guidelines that you can use simplification therapies. But the key is that issue for us, for second line, for the question, what is the sequential second line therapy? Somebody who's failed TOD, the second line therapy should be TO darunavir or TE darunavir, whichever you have. I think the lab is going to talk more about this, that as you are transferring these samples, important to maintain cold chain, and depending on where you are, you can either transfer the patient or the sample. We prefer that you transfer the sample first, then later on you can take the patient to the ATCs. You can see there has to be communication, especially those who you intend to send to the ACTs. Then you transfer the sample to the referral lab, then it goes to the ATC lab, then the results will come back and you can refer the patients later on. But the communication should start on what is there. So this is the pathway. Yeah. Obviously, genotype that we are doing has got its own limitations. That's why we are trying to be careful with it. It's very costly. Sometimes you cannot pick anything. If the variants are a minority, must only be done if an individual is at least been on ART for about 4 weeks. Yeah. In most cases, absence of resistance should be interpreted carefully in relation to prior treatment history, because you do have things like archiving and the like. Yeah. So it's not straightforward. So for those people who are supposed to be taken to third line, these are the individuals who are supposed to be taking care of them, just a few. Obviously, it should be a specialized team for individuals, for facilities running ATCs. We have requests that we, start ATCs even in other facilities. I think right now we do have a letter from Kitwe Central. Yeah, something that we've tried and it hasn't worked well over time, but we encourage that we continue working on that. But these are the people that we need. And these are really the options depending on who you are. So for those individuals, group 1 who are failing first line with resistant mutation to PIs, based regimen, but not sensitized to DTG. If you're on second line, they're on a PI-based. These can be put, especially if they are on lopinavir or atazanavir, they can be put on DTG, some darunavir. You can even put them on DTG alone and just TDF or other options that you have. For those individuals that are failing second line with a PI-based regimen and they have resistance to DTG and a resistance to NRTIs, these should be put on darunavir, ritonavir, 600, 100, and DTG as well, 50 milligrams. Then those who are failing second line DTG-based regimen, but they've never taken a PI, so you take them to a PI, you can add some atravirin. There are those who clearly have both DTG and PI mutations. You can still use a higher dose of darunavir, and we plan to add lenacapavir. So there's a plan to procure lenacapavir for those with extensive DRV and DTG mutations as prescribed. Put here. So I think the summary key points that I wanted to share is HIV drug-resistant testing for first line should be done in HIV drug-resistant surveillance sites. HIV drug resistant testing should be done for second-line treatment failure in all sites. Yeah. Support for referral to ATCs, that's either the lab or a patient, for the testing should be supported by partners and your offices. So, yeah, for everyone who has a PI failure, that is, they have second line failure, especially those on PI, so that we can put them on second line therapy. Thank you very much. I think we are going to go into the next presentation, I believe, then we can take questions after that.
All right, great. Thank you so much, Dr. Sevilla. That was a very insightful presentation. So if you've got any questions, network, kindly continue posting them in the chat box. I know some of your questions we may be answered in the next two presentations. But yeah, please post them in the chat box or keep them, and we shall have a Q&A at the end of this all. So at this point of time, I'm going to invite our next speaker, Dr. Rutaguera. So we're just setting up for Dr. Rutaguera. Great, thank you. So once again, thank you so much, Dr. Rutaguera, for coming to ECHO, and we're looking forward to your presentation. Over to you.
Thank you very much, Naik, and good afternoon, everyone. First and foremost, I'd like to thank Dr. Sevilla for a wonderful presentation. And basically, I will skip several of my slides so that I don't repeat what Dr. Sevilla just said. So don't be surprised when I skip slides. It's because basically some of the things I intended to talk about, Dr. Sevilla has already ably addressed them.
Okay. So this brings us to our first poll question. And our first poll question reads, how can emergence of HIV drug resistance be stopped? So A, initiating ART, B, blocking HIV replication, C, promoting good adherence, or D, lowering the genetic barrier of ARV drugs. How can emergence of HIV drug resistance be stopped? So let's all ensure you participate. Remember, your responses are anonymous. We're all here to learn. So some good response so far. How can we stop the emergence of HIV drug resistance? A, initiating ART, B, blocking HIV replication, C, we promote good adherence, D, lower the genetic barrier of ARVs. All right, so I am going to end the poll question soon. All right, so sharing with you the results. Dr. Rutaguera, we've got 89% that have opted for C, which is promoting good adherence, with the rest 8, 9, and 7% for option A, B, and D. And I'm sure we'll learn more during the session. So we'll go to our next slide here. Yeah. Over to you.
Thank you very much. So basically, HIV drug resistance occurs when drugs that were working stop working. That's the basic fact behind HIV drug resistance. Some drug was working, and then at some point it stops working. And by working, I mean actually blocking replication of HIV. And often we describe 3 types. So there's acquired, transmitted, and pre-treatment HIV drug resistance. So acquired drug resistance is what we talk about mostly because this is the drug resistance that emerges because somebody is on ARVs. So you are taking your ARVs and eventually you develop drug resistance. But also a drug-resistant virus can be transmitted. So you're transmitting this virus that already has HIV drug resistance mutation, and you may end up developing resistance mutation because of that. And then when you hear people talk about pre-treatment drug resistance, you're talking about either of the two, as long as it's detected in an ARV-naive individual who is initiating ART. So this is more like if you were doing baseline drug resistance testing. What would find in those patients initiating ART, that would be pre-treatment HIV drug resistance. Or if we're doing drug resistance before we initiate people on ART, defaulters on ART, what would find would be described as pre-treatment HIV drug resistance. So I think this is important to know. We always say that poor adherence actually leads to drug resistance, but it leads to drug resistance indirectly, because the problem with poor adherence is that we are allowing HIV to continue replicating. And as long as HIV is replicating, we are going to have mutations, we are going to have recombinations, and some of these actually might confer drug resistance to these viruses. So the key thing really is the reverse transcriptase engine of the virus is error prone, it makes mistakes, and during replication, it shifts back and forth between the templates, RNA templates in the virus. So if you can imagine several viruses in one cell, it's very easy for the enzyme to switch between maybe templates from different viruses. And that's what leads to recombinant viruses that are circulating currently. And then just one mutation will not cause resistance. You need a number of mutations to cause resistance. And number required to confer clinical significant resistance is often referred as a genetic barrier. If you read about DTG, to say that has a high genetic barrier, what does that mean? It means that you need several mutations actually to cause drug resistance to DTG. So I think Dr. Sivira has talked about this. I will not repeat. And then how do we block emergence of HIV drug resistance? So the only way you could do that is by stopping HIV replication. That's the only way you can actually stop the emergence of HIV drug resistance. How do you block replication? Obviously, you use drugs currently, that's the weapon we have, but also good adherence plays an important role. But you have to make sure that it's adherence to an effective combination therapy. It's not adherence to anything. It's adherence to effective drugs. So in Zambia, as Dr. Sivile mentioned, mainly there are two programs monitoring HIV drug resistance. So we have the routine HIV drug testing, and we have a surveillance system. So under routine, basically clinicians will request for drug resistance testing or genotype resistance testing for their patients. Whereas under surveillance, we're talking about a program embedded in the routine HIVDR or the routine testing program, but also leveraging on the viral load program, because post-EAC samples for individuals failing first line that are still unsuppressed are routinely or reflexively referred for HIV drug resistance. So results for both programs are used for patient management, but for surveillance, as Dr. Sivile mentioned, the main important is basically policy. So we have 3 labs currently processing these samples. So 2 labs are in UTH, that is ACOE and PCOE. And then we have a lab in Dollar at ADCH. In terms of performance, in the last financial year, that is October 2024 to September 2025, a total of 369 samples were received. So, and we have disaggregated the data by month and by lab. So the blue color represents the ACOE lab. The orange, that's the PCOE lab. And the gray, that's the ADCH lab. So as you can see, most samples are processed in UTH and mainly by the ACOE lab. So prior to the work stoppage order, we were receiving in the range of 50 samples every month for drug resistance testing. That significantly reduced during the months of the work stop order. And in May, we started picking up, but we seem to have reached a plateau in a way, although it's early to say. And basically, we attribute that to the recommendation in the minimum package, which has drastically reduced the number of samples that were actually sent for drug resistance testing.
All right, great. So this brings us to our second poll question. And our second poll question reads, so this is a true or false question. HIV drug resistant testing for individuals failing first-line ART should immediately stop as the country transitions to the implementation of the minimum package for sustainable HIV service delivery. True or false? So HIV drug resistance testing for individuals failing first-line ART should immediately stop as the country transitions to the implementation of the minimum package for sustainable HIV service delivery. Option A being true and D being false. Great participation. Let's all ensure we participate. This is very good network. In just a few more seconds before we close, let's all participate. Let's all try to put in an answer. All right, so sharing with you results, Dr. Taguera, 76% majority have opted for option D being false, with the rest being true. And I'm sure we'll learn more. So back to you.
Thank you. So of course, the answer is false. So the greater majority was right. And mainly that's because we are still doing surveillance and we still do HIV drug resistance testing in some individuals failing first line in some sites. Okay, so brief comments about last year's performance. So the 369 samples collected represent about 50% of what was processed in the previous financial year. So basically, we recorded a 50% reduction in number of samples coming to the lab. And when I say 369, that includes both cadre and routine testing samples. So traditionally, we've been receiving about 700, between 700 and 800 samples every year for processing since 2021. But last year, we received 369. Like I said, the two main reasons is the work stop order and the minimum package. Now, this reduction has created a problem. So we ordered reagents to process about 700 to 800 samples. Now, we've only used half. We are remaining with about half not used. And actually, there is some in the pipeline also. So we really need to look at this and see what we can do to make sure we do not have expiries. So what we had proposed is to have some kind of a waiver on the implementation of the recommendation of the minimum package, at least until we are able to say that now we have stabilized the reagent issue. And I think that was approved. Yeah, and maybe Dr. Sivile will say more on that. So the next, I'm going to give an update on the cadre ZM. So this is basically a slide showing regulatory approvals, what has been done, the type of study it is, and how many hub labs are participating. And each hub lab participating actually comes with all the sites that it supports. So if you're talking about, for instance, Mumbwa District Hospital, it's Mumbwa District Hospital, and all the other sites in Mumbwa District that actually send samples to Mumbwa District Hospital. So the sample size, we intended to have about 2,000, but we've realized that we will not be able to achieve that. And we have made changes because of that. So in Cadre, we were basically processing remnants of post-EAC samples. Like I said, these were reflexly referred to the 3 drug resistance labs. And they were moved by the interprovincial courier, which moved samples from all PCR labs to the drug resistance labs, either in Lusaka or Ndola. And once these samples reached the lab, we repeated viral load testing, basically to determine whether the sample is eligible for drug resistance testing. And we sequenced 3 regions of the POR gene of the HIV, and that's the reverse transcriptase, the protease region, and the integrase region. And this basically is because these are the main drugs that we are using in the national program. So the number of sites that were selected to participate in Cadre, so in the northern region, that's the region that was previously supported by USAID. So I had about 11 hub labs selected. So we have hub labs in Mumbwa, in Kalurushi, in Kabwe, in Luansha, in Chelenge, Solwezi, Iteztezi, Nampundwe, that's Uyunji, and then Muflila, Pika, and Isoka. In the southern region, traditionally supported by CDC, we had 12 hub labs selected and their facilities. So they represented Lusaka, Western Province, Eastern Province, Southern Province. Yeah. One thing to note is that we didn't have any facility from Northern Province or any hub lab participating in Cadre from Northern Province. And the main reason basically was that when this sampling was being done, Northern Province and Chinga were still one province. So in terms of sample flow for Cadre, in total from April 2021 to June 2025, we have received 434 samples. And of these samples, 20 were rejected. And then after repeating the viral load, 77 had the viral load that's less than 1,000 copies per ml. So what this means basically is that the viral load had deteriorated during transit or during storage before these samples actually reached the drug resistance lab. And as a result, we only processed 337 samples, which represent 77.7% of all the samples that were referred to the lab for drug resistance testing. So of importance here is to note that about 17% of all the samples that were sent had quality issues. The viral load deteriorated, basically pointing fingers at the way we are handling these samples. And I believe that's why Dr. Sivile was talking about maintaining the cold chain of these samples and preferring plasma referred. Okay, so of the 337 samples, We had a low sequencing success rate for the PRRT region, so that's the protease and reverse transcriptase region. And this basically is a widespread problem, and I think it's because of the new kit we are using. It looks like the primers for the protease and reverse transcriptase gene are not working well, so this is something that's being worked on. For integrase region, initially we had a poor success rate, but we worked on this, and in the last financial year, the success rate was 90%. But because we are getting an average for the whole period, that's why it looks like it's at 61.6%. But if you look year by year, you will see an increase in the success rate for drug resistance. Yeah, sequencing success rate. So in terms of results, overall, basically, we have very low resistance to PIs or protease inhibitors, and the range is between 1.3 and 4.6. For NNRTIs, the culprits, the usual ones, basically, they have high rate of high-level resistance. So those 2,3-TC and FTC have quite high resistance, but tenofovir has quite very low drug resistance rate, which is a good thing because that's a backbone for our first-line regimens. And then for NNRTI, nevirapine and efavirenz, quite high. For the rest, it's basically below 10%. For DTG, so high-level DTG resistance among individuals failing ALT is at somewhere around 18.4%. But if you talk about intermediate to high level, it increases to 22.4%. And I must note that we are talking about individuals failing ALT. We are not talking about everyone on ALT. So this data only applies to individuals that are failing ALT. Yes. And after EAC, very good. Yeah, that's very important. So these are individuals who are not suppressing after EAC. So about a quarter of them or a fifth of them have DTG drug resistance. And half of them will have either NRTI or NRTI drug resistance. So the major mutation detected are listed there for those that are interested, and we can actually provide this data. So as you can see, all the major known mutations that affect integrase have been detected in our country and actually in our provinces. So I think that's all about results. There's also some data on cabotegravir. If you're interested, we can share this. But I think what's important to note from this meeting is that because of the slow flow of samples, the cadre protocol was amended. And like I had already shown, the amendment was approved in September 2025. So in this amendment, basically, it has widened the number of sites that are participating in the cadre. And maybe that's the key information to note. So the difference between the new protocol and the old protocol, so basically we are trying to get all samples we can get to reach the sample size. As I mentioned, we only have about 147 samples that have DTG results. We are supposed to have at least a minimum of 400 samples. So, and we have to do this before March this year. So basically, we are trying to get all the samples that we can get. And we have added research questions. One of them is about 12 months outcomes following detection of HIV drug resistance testing. So in addition to doing drug resistance, 12 months later, we'll follow up and see what has happened to this patient actually. Did they switch or did they decide to maintain the regimen? If they switched, what was the outcome? If they maintained the regimen, what was the outcome? And the rest of the site will talk about basically sample processing. And the key thing really to note is that we need to correct 2 tubes if we want drug resistance to be done. And these 2 tubes, plasma should be separated on site, and we transfer plasma to the hub lab, either using so separation can be done either using a centrifuge, or we can allow the sample to stand at room temperature for about 2 hours, and then transfer plasma in a cryovalve or in a Panther aliquot tube. In the hub labs, basically these samples will be entered into dicer, they'll be centrifuged, and they'll be stored for referral to the PCR lab. And from the PCR lab, the samples will be referred to the drug resistance labs. In the drug resistance lab, basically drug resistance testing will be done. We'll genotype integrase, protease, and reverse transcriptase genes, and we'll try to have a result turnaround of about 30 days. But this is within the lab. It excludes the number of days the sample will stay at the PCR lab and at the hub lab.
All right, so this brings us to our last poll question. And our last poll question reads, oops. Okay, so sorry, there's an all right, so our last poll question reads, whole blood for genotype resistance testing may be stored at room temperature for a maximum of A, 2 days, B, 8 hours, C, 4 hours, or D, 2 hours. Whole blood for genotype resistance testing may be stored at room temperature for a maximum of A, 2 days, B, 8 hours, C, 4 hours, or D, 2 hours. So some great participation so far. Let's all ensure we participate. For how long can we store these whole blood samples for genotype resistance testing at room temperature for? Okay, so I am going to end the poll question now. And sharing with you results, Dr. Itaguri. I've got 36% who say 2 hours, 26% that say 2 days, and then 20 and 17% that say 8 hours and 4 hours, respectively. So over to you.
Yeah, so basically the answer is D. So no more than 2 hours. And that's why we are proposing that if you allow your sample to stay at room temperature for about 2 hours, just go and aliquot that plasma, put it in a different tube. Otherwise, if you keep it for more than 2 hours, that creates problems in the process. So for plasma, we can store it at 228 for about 24 hours, and then at -20 for about a week, and at -80 indefinitely. Most of our PCR labs have -80 freezers, and basically this is where genotyping samples should be stored. And we prefer plasma is moved rather than whole blood because hemolysis inhibits PCR. And then we have to make sure we minimize the freeze store cycles, less than 3. So basically what that means, we need to store several aliquots of the same sample. So that, for instance, if you want to do viral load on the sample, you don't have to sort the whole sample. You just pick one aliquot, work on it, And after you work on it, you discard the report you've worked on it, and you remain with those frozen for further processing. And then we need to actively monitor the cool boxes that are transferring these samples. For instance, if you are receiving the sample, you need to know at what temperature you are receiving these samples at. And if they are at room temperature or they have thawed, basically we need to discard them because they will not work. So another key important thing to note is the viral load requisition form. So we need to feed in all the information that's needed. What we've learned is that section 4 usually is left blank, but this is what we need for surveillance. So we are urging all the clinicians or everyone filling in this form to make sure section 4 is filled in, and section 2. Actually, all the sections should be filled in. Otherwise, it becomes very difficult to include this sample in the surveillance system. But also, as Dr. Sivile mentioned, it's difficult to interpret these results without the history of the patient. So please, let's make sure we provide the required information. So the sample courier, we are using the integrated courier system to move these samples. And this is how the provinces are zoned to the different drug resistance labs. So if you're in Central, Copper Belt, and Northwestern, you probably send your samples to Ndola, but for the rest of the country, the samples will come to UT. So what lessons have we learned? Our EAC program is very porous. I think Dr. Sivile illustrated that very well. We have quality issues that we need to resolve, and we are actively working on these issues. Documentation is still an issue. Basically, we need to encourage all of us to make sure we provide all the information required and actually provide accurate information. And then result interpretation and acting upon is still an issue, especially in lower levels of service provision. And basically, we need to devise system to support these facilities. This is my last slide. Thank you very much.
Thank you so much, Dr. Togera. That was indeed a very lovely presentation, very insightful. I know we do have quite a number of comments in the chat box. We shall get back to that. So we're done with our presentations, but we have a short presentation, not really a presentation, but I'd like to invite Miss Judith Mziache to say a few things about the HIVDR cascade. So over to you, Miss Mziache. I hope you can hear us.
Good afternoon. Yes, I can hear you. Just confirm that you can hear me.
Yes, we can hear you. Thank you.
Thank you so much. I'm glad that okay. Dr. Sivile and David have highlighted most of the important issues regarding the viral the HIVDR testing, and I know we do get a lot of questions from the provinces why we can't do it in the province. Why do we have to send the samples to UTH? So apart from what David explained, why we have kind of centralized the testing is the issue of the issue of cost. And like Sivile did share, that we now have a minimum package of care. So that minimum package is all about reducing on the cost, making the tests or whatever lab programs that we have, making them cost effective. So what us having to send to UTH for that, it's all about the test. So we want to please do not do any other things outside what David did explain, because if we have to request for repeat tests, we have to ask you to send other fresh plasma, or the forms are not correct. then where we are supposed to reduce or cut on the costs, we are not going to achieve that, because then we're increasing the cost of running HIV drug resistance testing in the country. So also the issue of the hub and spoke model that we are using, this is both for the sample referral as well as the testing. So this hub and spoke system that was that my two colleagues did speak to is actually just a method or a means to scale up testing and ensure that there is equity in our testing. So it follows our tiered laboratory network, and it's a critical aspect of our system because this is our model for efficiency. We have our spoke labs, which are the peripheral and the clinics, the district hospitals, whose role in the HIVDR is that they are the backbone for our routine national surveillance and also for the individual patient monitoring in the central reference labs. So the HIVDR testing is not just for the facilities in the central level or the provincial labs, but it starts as low as the peripheral labs where the spoke sites are. So we really need to ensure to package our samples correctly when we are sending them for testing. We need to ensure that we follow the instructions, ensure that cold chain is actually maintained. Issues on sample collection, I cannot overemphasize. David did touch on this. This is very critical. It's important because the way we collect the samples and also the way we process them in preparation for transportation, they will impact or influence the type of results that we do have. So sometimes we may feel that our sample referral system is not stable or it's not adequate, but when the key is ensuring that cold chain is maintained when transporting and that we package them correctly, and also the collection of the sample was also good. That way, when we follow this, we are going to maximize on the resources that we have, the little resource, and also it will help us to have a standardized quality, and it will actually create a clear patient care pathway if we were to follow that. Then just a little on what is the lab, the laboratory department media. So because we do realize that this is an important test that we need to provide to those clients, especially those that are studying the EAC. So we have actually integrated the HIVDR monitoring. It's one of the core components of the lab. And you will see that even in our strategic plan, it's also there. And when you look at also even what Dr. Sevilla was sharing, you've seen it is there on when and how, or when it should be performed, where and by who. So we have all these guidelines or plans in place which are supposed to guide us. And then on the funding, regarding the funding and its sustainability, we are working really hard to really secure domestic funding for it. We've quantified for it, we've planned for it, and there are some resources that have been allocated, and we're trying to prioritize the lab commodities for this. So in a nutshell, the government is really trying to do everything to maintain this, as has been explained by my colleagues. And we are depending on this, the data that we shall generate from the HIVDR to actually inform our future planning. And also this one, I'm sure it will also inform our national treatment guidelines if we have to ever update them. And we are working with a lot of partners in it. And we know that, I'm sure we all know that synergy is the key to building a resilient and a responsive system. We can't work alone. So you will see that a number of our partners that are around, that are available, they'll be coming through offering technical assistance and all that. They'll be following up on this. So what I can say in conclusion is that HIV drug resistance is actually a threat to global HIV response. And as a lab, this is a non-negotiable call for detecting and monitoring this threat. So we should really take it serious and prioritize it. And we really need to anchor or leverage on the hub and spoke system that we have, and because this is a sustainable model for our success. So those are my remarks or my thoughts on just adding to the two presentations that have been shared. Thank you so much.
Thank you so much, Ms. Mizete. That was very helpful in understanding what goes on. So at this point of time, we're going to quickly jump into the Q&A session. I'm also going to invite our experts for today. We have Dr. Sombo Foloshi, Mr. Mpanje Sibinga, and Ms. C. Chileshe that will be joining us on the panel. So welcome to our panel discussion. So if you do have any questions, again, please kindly post them in the chat box or raise your hand and we shall be able to attend to them. So there's already a few questions in the chat box for our three presenters today. So our first question from Dr. Phallus Lipita, thank you for that. So what about a client? So this is a question, what about a client who has completed 3 EAC sessions and barriers have been addressed? Post-EAC viral load turnaround time has prolonged from 8 to 12 weeks. How do we address this? So this is one of the questions. Also, Florence Zulu has raised a similar, what strategies have been put in place to address the genotype results for TAT? And then Chikumbi was asking, does this apply to PMTCT? And another question about turnaround time as well. Maybe we could do those first.
Thank you, colleagues, for those questions. So indeed, the turnaround time has been affected because of the stop work order. Before that, almost everywhere we were below 2 weeks, but now you have those extended time points. I think the answer to that is first, to work on the reasons why the turnaround time has increased. So it has to do with courier. So where you are, let's work on the courier system, integrate them, but also let's make use of the point of care testing platform. So right now, the guide is samples for post-EAC testing should be done where possible on POC platforms. Yeah, that's a GeneXpert, so that you avoid that trouble. So I'm sure you know that guidance that for those priority viral loads, that's pregnant women, young, what you call them, children, and so on, including ESC, post-ESC samples should be done on POCs. We have a lot of POCs in the country, 255, and I think now should be close to 300. Judith can give us the correct number. So yeah, so just talk to the lab to see that that can be done faster. But where you don't have that POCs, you're in a big facility, you can still try and expedite the process. There are a few provinces which still have challenges, but I think we can solve those bottlenecks. Yeah, indeed, for pregnant and breastfeeding women, it's another discussion. So you don't really have to go through the ESC. You go ahead and switch still to effective therapy. I think we've discussed that at another fora. What was the other question, Doc? Did I missed anything?
Addressing TAT was
Yes, TAT, yes.
That's about it. So, yeah.
Maybe an additional comment on the TAT for drug resistance result, the genotyping result. So basically, this can be split into two. There's the time the sample spent in the drug resistance lab or the drug resistance testing lab. This we have resolved. So it shouldn't take more than 4 weeks in the lab. But there's also an aspect of how long the sample takes for it to reach the lab. And this is what I think probably also needs to be looked into, so that at least if samples can be sent to Lusaka twice a month, then we could correctively reduce the turnaround time of drug resistance result to acceptable ranges. But if a sample is going to spend a month in the PCR lab, or 2 months or 3 months, you add another month in the drug resistance lab, we'll go back to the turnaround times of the past. Thank you.
So the question was somebody who's post EAC and you are waiting for the viral load and it's taking longer. Yeah. So you've seen from the data that over 70 to 80% of people who go into EAC, they actually resuppress. Of those that don't resuppress, they still have high viral load after EAC. Only 18% have DTG resistant. So you can do the maths. You find that very few individuals actually who have that mutations after DTG. And that's the reason that we insist that this surveillance is done for DTG, because DTG resistance is still very rare, and DTG should still work in most of the patients, even those that are failing. So with that, give it time. No rush to say the viral load is not coming soon, so let's just switch to second line after ESC. No. So the likely probable event after ESC is that somebody will resuppress. If you're ESC, the barriers were done, they are good, they have started taking the drug, they will likely suppress. Yeah, there's just that few proportion. So the issue is just to work on adherence. Even when you're waiting for that long TAT for viral load. But still, let's work on the TAT viral load. Thanks.
Thank you, Dr. Sibile and Dr. Taguera. So just a few more other questions in the chat box. So this is a question from Dr. Jumbo. So darunavir is featuring strongly in third-line regimes. The reason in other settings it's reserved for third line. Don't you think its use in second line as recommended may compromise future third line options? So thanks for that question. Then we've got another one from Chikumbi Chambwe from Siders. Says, how does the virulence of a mutated HIV strain compare with that of the wild type virus? Yeah, maybe we could do those two. I know there's a few questions that Mpanji has answered. Thank you, Mr. Mpanji, for taking those. So yeah, so darunavir in third line. Now we're going to use it in second line. What are your thoughts? Won't it compromise future third line options?
Yeah, so a few comments on that one. Yeah, so the first one is the dosages are different between second and third line. So the third line, darunavir, the dosage is higher. It's 600 100 milligrams, that's BD. And you do, which is like 1,200 of darunavir there and 200 of ritonavir. And the doses in second line is lesser. So from previous trials, even after failing that second line for darunavir, depending on the type of mutations that you have, you could still use it in third line with a higher dose. Now, that's the science. But the programmatic reasons why we made that the decision was we had reserved it for third line for over 10 years, 10 to 15 years, and the third line cohort has not grown. And for information, we haven't had a true failure in the third line. So the decision was made to say, why not bring better drugs? Because darunavir is a third generation PI, and it's better if used. So in third line, we have so much experience. It's a very better PI side effects profile. So why are we keeping a good drug for third line, and yet no one is going to third line? Because very few patients are failing. So why don't we bring it, easier? So when we were the decision was to move better drugs to first line. Similarly, instis were moved. When initially we were using raltegravir for third line, we said, let's have instis to first line, and we bring darunavir to second. And that has worked well. So far, we haven't had anybody failing second line darunavir to go to third line. I think this is now 2 years or so experience. So the idea is to avoid so many lines where someone goes up to fourth, fifth, sixth lines. So you've seen that over the 15 years now of this third line, we haven't had need to come up with a fourth or fifth lines. Yeah. So that's one of the reasons. The third reason, or the last reason, is obviously we are very sure of newer better drugs, like we've said. Lenacapavir, as you know, has now been approved in the country. We even have some doses, injectable be it, but it comes with the oral. So we do have that pipeline where we knew that these better drugs like lenacapavir, which has been used in Europe, I think the past 2-3 years for salvage therapy, we knew that it was coming. So we're confident that these can be used in the event that we can't use darunavir.
Thank you, Dr. Sivile.
So I'll ask maybe Dr. Folosh to talk about the wild type. So if there's no one else on the chat, so the replicating ability or speed, you could call it, for mutated viruses is less than that of wild type. So that's why when you stop your ART, the wild type, they will grow faster and they become the predominant subspecies in the blood. That's why you want to have somebody on effective therapy so that you kill off the wild type, and then you can allow this resistant subspecies, quasi-species, to actually grow. So they don't grow as fast as the wild type. So it's slightly more virulent. Yeah.
Thank you so much for that. So I think some of the questions Mr. Mpanji has answered. This was a nice case from Peter Singongo Police Urban Health Center. A client who was not failing on TLD but was gaining weight from 74 up to 108 kilos, reached a point where she refused to continue with DTG. And then took atazanavir and started reducing weight with time. But they ran out of atazanavir at some point and took her to lopinavir, where she had continued coming down in weight to 80 kilos. And so that was TDF, TTC, and lopinavir, ritonavir that they moved her to, and wondering if that would affect her future management. And I think you've kind of covered that a little.
So I think we should have a session, a co-team between these metabolic side effects. I think it should be one of the topics. So unfortunately, they do occur. So TOD, TAFED is even, one would say, worse. So we've made some cases, but I think you've seen the guidelines they have some principle. It's an increment of over 10% BMI, which is morbid, and I can't remember, but we've put something in the guideline, and it's very nice that you acted and you see those results. Thank you.
Great. So I think we've just got a few more questions left. So This is from Chisomo. If a patient shows resistance to one drug, do we maintain other drugs or we change the whole regime? Which is a great question. Yeah. So I think that's.
You want me to answer that one? So initially, in principle, people used to say when ART heart, as it was called, in 1995, 96, first given to Magic Johnson, when it started, that principle was not probably advised that you change only one drug and leave the rest. Now we do have strong evidence. I showed you the WHO and we've presented on the fora several clinical trials. We've done clinical trials here ourselves. We've the Vicent, we've analyzed mutations in the Vicent. So it does show that if you are failing TLE, for instance, if you just change the E to the D, the regimen will be strong enough. If you are failing TLD, if you change the D, it's another D, the darunava. Yeah, if you change the dolutegravir to the darunava and leave the rest, the backbone as it is called, potent, you are still having a very efficacious therapy. So everybody feels that probably the previous teaching might not be the correct. And now we do have, I think we've said a lot about this on this platform, the recycling. Now we do have evidence, and it's now in the guidelines from the WHO that there are certain, you can just change the D to the other D.
Yeah. Great. Thank you for that explanation. So, yeah, we do have our NNRTA backbones that we recycle, like Dr. Sibile said, and usually changing one drug may make your entire regime so much more efficacious and stronger. So another very interesting question, God forbid this ever happens, what is the time frame for someone to have drug resistance after missing due to an outstock?
That's a tough question.
Very, very tough.
So, for instance, when they are doing the trials to see on a plate outside the body, they will sensitize and stop and just check the virus and see what happens. So even very few sensitization, a bit of months and so on. Yeah, but in practice, experts, for instance, for say TB drugs, people say you can go a month and not cause problems. Similarly, I think for HIV, yeah, but it's a difficult question. Yeah, pointless to say that on that list that I showed of people who developed DTG resistance, there was an 11-month-old child. Yeah, and we believe that that particular child, it wasn't transmitted resistance. Yeah, it's because the mother didn't have the problem. Yeah, and was never on. Yeah, so it was okay. And so in other words, the child was given DTG, the PDTG for less than a year, and we could see resistance. So it does. In other words, you don't need years for you to develop resistance, even a shorter period of time. In a test tube, days or months, they'll still pick that. Yeah.
Thank you so much for answering those, Dr. Sivile, Dr. Ritoguera. We don't have any more questions in the chat box. Anybody to raise any hands, any last questions that we need before we end this session? So far has been a very nice Q&A. Any last questions? Okay, so it seems like we don't have any more questions in the chat box or any hands raised. So this brings us to the end of our presentation. I think for the next few days, we'll be having some presentations from the provinces I'm sure was communicated. So each of the provinces will be presenting from tomorrow onwards in a separate echo session. So we are looking forward to that. So at this point of time, I'd like to thank you all, and a very big thanks to our presenters for today, Dr. Sivile, Dr. Taguera, and Ms. Mzieche for today's presentation. And a very, very big thank you to our network who have been so attentive and very responsive. And we'll catch you next time on our next HIV-TB Echo next week on Monday. Thank you and enjoy the rest of your day.
Thank you. Signing off.